Good morning, good afternoon, and good evening to everyone. Welcome to the ISGyP LiVE Journal Club. So our theme today is ovarian epithelial neoplasms. I'm Becca Wolsky. I'm speaking to you from the University of Colorado in the USA. And today, Natalie Benet is joining us as well. I think we might have Jenny Bennett here as well. And Dr. Hagemann, Ian Hagemann, is on vacation. So before we get to our programming, I'll draw your attention to the upcoming ISGyP Live events. On June 28th at noon Eastern Time USA, Dr. Marissa Nucci will be speaking on the ISGyP Live podcast about the ICCR guidelines for reporting uterine malignant and potentially malignant mesenchymal tumors. That's moderated by Jacqueline Watkins and David Chapel. Also on June 28th, Jenny Bennett and Rabina Wadi will be moderating the interesting case presentations by trainees or early career pathologists. So we're excited for those. Register for all those events if you haven't already. A reminder that the ISGyP Journal Club is global, with the Western Hemisphere occurring the third Wednesday of every month at 12 noon Eastern Time. And the Eastern Hemisphere is the third Thursday of the alternating months at 12 noon Melbourne time. So here's the schedule of topics through 2023. In July, the Eastern group will present a journal club on germ cell tumors and gestational trophoblastic disease, which I'm really excited for. A reminder, we do offer detailed mentorship leading up to these presentations. So if you're interested in presenting at either journal club or interesting case presentation, please reach out to one of us via the emails listed here. So now to the main event. Our three volunteer presenters today are Dr. Manisha Goel, a second-year anatomic and clinical pathology resident at the University of Chicago. Next, Dr. Amany Hassan is a lecturer of pathology at Mansoura University, joining us from Egypt. And finally, Dr. Archana Sallagonda is a PGY3. Of course, we're about to change over the year, so rising PGY4 at the University of Massachusetts Chan Bay State Health Center. So thank you to all three of you for your hard work. The articles to be presented are listed here, and I'll let each of you read the title of your article at the start of your presentation. The objectives for this journal club include engaging trainees and early career pathologists, offering opportunities for presenting and moderating to members from all parts of the globe, and providing mentorship in engaging future leaders like you from around the world. So here's the outline and assignment for our three presenters. And here's our schedule for today. So first we'll hear from Dr. Goel, followed by Dr. Hassan, and finally Dr. Sallagonda. So as a reminder, we're in a webinar format. Please use the dedicated Q&A or question and answer for questions to the presenters and moderators with the option to upvote questions. And please go ahead and use that chat to say hello to everyone and let us know where you are in the world. We'd love to see that. So now I'm going to stop sharing my screen, and then Dr. Goel, you can share your screen. And I'll ask the other panelists to please ensure that you're muted, and feel free to turn off your cameras as well if you're not presenting.
Okay, thank you so much, Dr. Wolsky. Can you see my screen well?
Yes, you're good to go.
Great. Thank you so much, everyone, for joining us this fine afternoon. I'm Manisha Goel. I'm a second-year resident at the University of Chicago. And today I'm going to present the paper on atypical endometriosis and comprehensive characterization of its clinicopathologic, immunohistochemical, and molecular features. This study was published this year by Wepy et al. In the International Journal of Gynecologic Pathology. First, I'd like to start with a brief introduction about endometriosis and its evolution as a pathological entity. So as we all know, it's a chronic estrogen-dependent progressive disease, which occurs in approximately 10 to 15% of reproductive aged women, and is characterized by the presence of endometrial-like stroma, glands, or other findings of chronic bleeding outside the uterine cavity. Most common sites for this entity have been described as ovaries, fallopian tubes, and pelvic peritoneum. Atypical endometriosis, on the other hand, is a rare entity which comprises 1.7 to 4.4% of all the endometriotic lesions. As defined by WHO, the histological features of this entity are characterized by proliferation of crowded glands, which are lined by atypical epithelium, or endometriotic cyst with alteration in its lining, which is usually represented by presence of stratification, disorganization, or cytologic atypia. Association of endometriosis with neoplasia was first observed in 1925 by Sampson, who described endometrial carcinoma of the ovary arising in the endometrial tissue. This association was further established in 1953 when Scott observed atypical changes in endometriotic foci, in addition to presence of benign endometriosis in proximity to the endometriosis-related cancer. It was in 1988 when atypical endometriosis was proposed as a transitional step between conventional benign-looking endometriosis and associated epithelial neoplasms. And multiple studies later on established endometrioid and clear cell carcinomas as the predominant histologic subtypes associated with these lesions. Most recently, multiple studies have also described the molecular features of endometriosis, particularly the deeply infiltrating ones, and have shown cancer-associated mutations in ARID1A, KRAS, and PTEN, among others. Of note, these mutations are commonly encountered in the cancer subtypes which have been associated with endometriosis. But even with all these developments in our recent understanding of endometriosis, our understanding of endometriosis-related neoplasia, the biological link between atypical endometriosis and malignant progression still remains unclear. Thus, the authors through this study sought to refine the morphologic, immunohistochemical, and molecular spectrum of atypical endometriotic lesions and further identify features with EMS-related neoplasia. They conducted this study on the cases previously reported as atypical endometriosis, which were identified by a retrospective database search. Of approximately 4,600 cases of endometriosis identified during a period of 2010 to 2021, 36 cases were those of atypical endometriosis. And all these 36 cases underwent detailed histologic review with documentation of listed points on the slide. Immunohistochemistry for hormone receptors like ER/PR, Nepsin-A, Ki67, P53, PMS2, and MSH6 was performed in 33 cases, while next-generation sequencing was performed in 6. Patients ranged from 26 to 58 years of age with a mean age of 46 years. Among these 36 cases, ovary was the most common lesional site. Mean percentage of atypical cells ranged from 5 to 100% with a mean of 79%. Cytologic atypia was divided into 3 categories based on nuclear size comparison with endothelial cells. Moderate cytologic atypia was most frequently observed, which was defined by the nuclear size approximating twice the size of endothelial cell. Hobnail nuclei were identified in most of the cases, while a subset of cases showed presence of associated neutrophils and metaplastic changes. A variety of architectural patterns were observed, with 16 cases demonstrating more than one pattern in these cases. Most common architectural pattern observed was flat, as shown in the first top left picture, where no to minimal cell stratification is evident. Hobnailing of cells can also be identified in this particular image. Other architectural patterns observed were micropapillary, which shows tufts of epithelial cells projecting above the plane of lining, but devoid of any underlying stroma. Crowded glandular architecture was defined as tightly packed glands, with glands representing more than 50% of the surface area, while cribriform patterns showed proliferation of the epithelial cells, forming these smaller secondary lumina. Immunohistochemistry was performed in 33 cases, and most of the cases showed positivity for hormone receptors, including ER and PR. Nepsin-A was found to be often positive as well. On the other hand, all cases showed wild-type P53 expression, which is characterized by this heterogeneous weak staining, and PMS2 and MSH6 showed retained nuclear expression in all the cases. Ki67 was rather low, with ranging from less than 1 to 10%, with a median of 5% in all these cases. So 9 of these 36 cases of atypical endometriosis did present with tubo-ovarian neoplasia. In 8 cases, the neoplasm was synchronously present, and in this remaining 1 patient, a clear cell borderline tumor was diagnosed 8 months after the diagnosis of atypical endometriosis. In this subset of 9 patients, crowded glandular architecture within atypical endometriosis showed a statistically significant association with neoplasia. Other histological features did not show this association. Next generation sequencing was successfully performed in 6 cases, showing mutations as listed on this table. In 2 of these cases, which are pointed out by the arrows, synchronous tumoral tissue was also sequenced separately. In both these cases, all mutations which were observed in the atypical endometriotic foci were present in the tumoral tissue as well, and both tumors harbored additional mutations on top of it. So overall, this study does expand the morphologic, immunohistologic, and molecular features of this rare entity, atypical endometriosis. First of all, it does reaffirm certain known characteristics of atypical endometriosis. Like in this study, 22% of the cases showed presence of concurrent or subsequent neoplasia development, showing higher prevalence of tumor in these cases as compared to previously reported lower prevalence of 1 to 2% in patients with conventional non-atypical endometriosis. However, study was limited by no documentation of cases of neoplasia in cases of conventional endometriosis at their particular center. Similar to previous studies, common histologic subtypes of associated neoplasia were found to be endometrioid, clear cell, and seromucinous. Another important outcome that was noticed on this study was that patients with associated neoplasia were statistically more likely to show glandular crowding, while other histological features were not statistically different between patients with neoplasia and those without. This finding implied that endometriosis with architectural abnormalities were more likely associated with neoplasia as compared to the presence of cellular atypia. The study also brought forth the immunohistochemical profile of this lesion, including positivity for hormone receptors, wild type P53, low Ki67, and retained MMR expression. This IHC profile could be used to differentiate this lesion from other common malignant proliferations, like high-grade serous carcinoma, which is P53 mutant and shows high Ki67. Clear cell carcinoma, which is often negative for hormone receptors, but may harbor abnormal P53, and endometrioid carcinoma, which may show deficient MMR staining. Napsin A positivity, on the other hand, in cases of atypical endometriosis, warrants caution, and its expression by itself should not be used to support a diagnosis of clear cell carcinoma. Study also showed that atypical endometriosis can harbor pathogenic mutations, lending support to neoplastic property of this entity. Besides, when they performed molecular analysis on paired samples of atypical endometriosis and neoplasia, which demonstrated the acquisition of additional mutations in the neoplastic tissue, suggesting that additional molecular events signal the progression to neoplasia and that the tumoral population is likely derived from the clone present in the atypical endometriosis and not the other way around. So this study brought several important features of atypical endometriosis to highlight. First is the proposed utilization of histologic and immunophenotypic features to support the diagnosis of atypical endometriosis. This was the first study to evaluate expression of MMR proteins and napsin A staining in these cases. Study also reaffirms the higher prevalence of neoplasia in atypical endometriosis and showed common molecular alterations between atypical endometriosis and synchronous neoplasia, further establishing the neoplastic properties of atypical endometriosis. Low sample size and molecular analysis of only 2 cases with paired atypical endometriosis and neoplasia were some of the shortcomings, and further studies are definitely needed, which could perform such paired molecular testing in more cases to fully characterize the malignant potential of this lesion. The study also doesn't describe the immunohistochemistry and molecular profile of non-atypical endometriosis, something which could be considered in the future studies to compare the similarities or differences between the two lesions. Another limitation which could be considered of the study was the case selection, which could have potentially suffered from a bias. Since only cases previously diagnosed as atypical endometriosis were included in the study, and cases of conventional endometriosis were not reviewed for presence of atypical features. Besides, 22% of these cases diagnosed as atypical endometriosis had presence of concurrent neoplasia, which could have led to diagnosing atypical endometriosis more comfortably by the pathologist in the presence of this known neoplasia. So based on the findings of the study, certain features could be put to practice when reviewing the cases with endometriosis. First and foremost is the crucial step of recognizing atypical endometriosis because of the associated prognostic significance and the need for close patient follow-up for the development of future neoplasia. Although the proposed criteria of architectural complexity and cytologic atypia should still be followed to diagnose atypical endometriosis, more attention may be paid to the presence of architectural abnormalities like glandular crowding, which was shown to have prognostic significance. And specific mention of this architectural abnormality and its implications could be considered to be mentioned in the pathology report. Finally, in diagnostically difficult cases, the following immunohistochemical profile could be considered to support a diagnosis of atypical endometriosis. So that was all from my side. Thank you so much, everyone, for your attention, and I'd be happy to take any questions now.
Great, that was fantastic. Thank you. So we do have a question, or perhaps two questions from our audience. So one question, which I think this is an excellent question, is how do you differentiate atypical endometriosis from endometrioid borderline tumor? And do you want to
Yeah, so I guess
shot at that, or?
Yeah, I can try and take a shot at that. Like, so in endometrioid borderline tumor, I guess the growth should be more confluent. Like it should have more confluent growth, I guess, as opposed to atypical endometriosis. Although they have described crowded glandular architecture, which occupies more than 50% of the surface area, but borderline, I think, needs to be more exuberant than that.
I think that this is an area of pathology where of course there will be cases with just focal gland crowding that probably most pathologists would classify as atypical endometriosis or focal atypia, and cases that are mass forming perhaps ahead of time on imaging where we're really suspecting a neoplastic process and it shows gland crowding to the degree that within the endometrium we would call atypical hyperplasia. That's more of a clear-cut endometrioid borderline tumor. There are absolutely cases, I just had one a few weeks ago, that are in the liminal space of, should I call this atypical endometriosis or endometrioid borderline tumor? So for example, these challenging cases where I'm not convinced there is a clearly defined answer right now, would be a case where it's diffuse endometriosis and then, you know, just a small subset of that is gland crowding with foci reaching what we would call atypical hyperplasia, you know, maybe just a few millimeters. Those are challenging cases. And I think in those cases, there's not a clearly defined size criteria for how much, you know, what we'd call atypical hyperplasia in the endometrium is needed to diagnose borderline tumor. And the important thing is to communicate with the clinician. And if you're lucky, you have clinicians where you can communicate these kind of, you know, difficult questions around the case. So we have another question. If a clinician asks what they should do for follow-up of atypical endometriosis, what's the answer? Dr. Goel, do you want to take a shot at that one?
So yeah, for sure. I guess one thing would be to follow up with the imaging, first of all, if there is, new development of any lesion, if there is like endometrial thickening, or basically adnexal lesion, development of a new adnexal lesion. I'm not entirely sure if they should follow up with, routine tissue diagnosis, because there are no clear-cut guidelines laid down for that yet.
Yeah, I think this may differ from institution to institution, but my understanding is, at least here at University of Colorado, so if we call it a borderline tumor, they might consider staging the patient as you would borderline tumor. Working on that. Can you excuse me for one moment? Check the home app. Can someone read the third question?
I can read it.
Thanks.
So the third question is, were they able to identify the distinct driver mutation which allowed progression of atypical endometriosis to neoplasia? So like there are multiple parts of this question. So the first part was that, which I just read. I would say no. They did find cancer-associated mutations in the atypical endometriosis and the synchronously developed tumor, but they really didn't identify a distinct driver mutation. They couldn't pinpoint that, okay, these mutations led to the progression of atypical endometriosis to neoplasia, although there were additional mutations present in the tumor, but I guess, and it was just done in 2 cases. So like there is still a little unsurety about that, I would say.
Okay. Apologies for that brief interruption. Thank you. So the question of follow-up for atypical endometriosis, I think this is probably a difficult question for the clinicians, and based on, some clinicians might feel that nothing is warranted and others will do some type of surveillance. And based on this paper, I think that not further surgery, but some type of surveillance may be warranted, but I don't know the details of how often and how many. All right, I think in the interest of time, we should move on to our next presentation. Thank you for these great questions. So we've got Dr. Hassan, if you'd like. So yeah, Dr. Goel, if you want to stop sharing your screen. And then Dr. Hassan, you can go ahead and share your screen.
You see my presentation?
Yes.
I am Amany Hassan, a lecturer of pathology at Mansoura University in Egypt. The article I will discuss today, Extrauterine Mesonephric-like carcinoma, a comprehensive single institution study of 33 cases. This work was done by Dr. Wepy team and published in the American Journal of Surgical Pathology in 2023. So Mesonephric-like carcinoma is a newly described entity in the WHO 2020. They are the carcinomas that share the histologic and the immunohistochemical features of mesonephric carcinoma, but lack an association with mesonephric remnant or hyperplasia. The extrauterine mesonephric-like carcinoma, the data about these are limited to case reports and the small series. Their rarity and heterogeneous histologic features pose a diagnostic challenge. Their behavior has to be delineated, although some reports suggest aggressive behavior. In this study, 33 cases of extrauterine mesonephric-like carcinoma will be discussed regarding the clinical, pathologic, molecular features, and the tumor behavior. So first, a search at the MD Anderson Cancer Center Department of Pathology database using the keywords mesonephric, ovary, pelvic, and peritoneum at the period between 2002 to 2022. The cases included the cases with the classic histologic features of mesonephric-like carcinoma with expression of GATA3 and or TTF1. The expression of hormone receptors did not preclude inclusion in the study. Cases with the classic histologic features but lacking GATA3 or TTF1 were excluded. First, the H&E evaluation. They evaluated the architectural patterns found in the tumor, like the ductal glandular pattern, the tubular, papillary, retiform. They evaluated also the cytological features, the chromatin quality, the nuclear contour, presence or absence of nuclear grooves and overlap, the number of mitosis per 10 high power fields, the presence or absence of intraluminal eosinophilic secretions, the presence or absence of endometriosis, presence of other histologic component or features mimicking a second histotype. For IGC evaluation, it's interpreted as focal, patchy, or diffuse. Regarding ER and VR, the percentage of nuclear staining is recorded. Cases with incomplete IGC results stained for TTF1 and or GATA3. And molecular analysis was done for 20 cases. For purposes of comparison, they selected a control group blinded to the stage at presentation, the outcome, and the recurrence. This group composed of ovarian low-grade endometrioid carcinoma, ovarian high-grade serous carcinoma, ovarian clear cell carcinoma, and endometrial Mesonephric-like carcinoma. And the comparison was recorded to the clinical, pathologic, and follow-up data. So the results, 33 cases was found, 28 cases ovarian, and 5 cases in the pelvic peritoneum. 3 cases has a primary diagnosis at the MD Anderson Cancer Center, and 30 consult cases. 26 cases had errant outside initial diagnosis. The most frequent misdiagnosis was endometrioid carcinoma low grade in 9 cases, and the grade 2 in 2 cases. And the grade 3, in 2 cases. Regarding the histological features, the architectural pattern is found. Most cases had at least a combination of 2 architectural patterns. The ductal and the glandular pattern is the most frequently encountered at 91%, followed by the tubular and the papillary pattern. Here is an example of the architectural patterns found in the first image. On the left side, there is this is a tubular pattern, and on the right side, the papillary pattern. The second image shows prominent ductal glandular pattern. In the third image, the solid pattern composed of spindle cells merging with a slit-like glands. The fourth image shows a prominent 6-cord-like pattern. Regarding the cytological features, all cases had a mild to moderate degree of cytologic atypia, with only 4 cases show foci of marked nuclear pleomorphism. Nuclear features similar to those of papillary thyroid carcinoma were present, nuclear grooves and marginated chromatin in all cases, nuclear overlap in 94% and angulated nuclei in 58% of cases. Intraluminal eosinophilic secretions was found in 32 cases. Mitotic activity range from 2 to 31 per 10 high power fields. Here is an example of the nuclear features, the optically clear nuclei with nuclear overlap and the nuclear grooving. And here's an example of the prominent intraluminal eosinophilic secretions. Regarding the associations, endometriosis was present in 21 cases, about 63%. 7 cases was associated with borderline tumor, and in 2 cases, the borderline tumor appears first, followed by the carcinoma in the recurrence. 14 cases, about 42%, associated with Mullerian carcinoma. The most frequently encountered type is low-grade endometrioid carcinoma. 2 cases were Mesonephric-like carcinosarcoma, with 1 showing heterologous rhabdomyosarcomatous element. 1 pure extrauterine Mesonephric-like carcinoma had heterologous metaplastic cartilage. 3 patients had incidental synchronous low-grade endometrioid carcinoma, FIGO stage 1 with no LVI. None of the cases had associated mesonephric remnants or hyperplasia. Regarding IHC results, first, the GATA3 and TTF1. GATA3 was positive in 31 out of 33 cases. TTF1 was positive in 24 out of 32 cases. Only 1 case showed the inverse staining pattern of GATA3 and TTF1. 7 cases show only GATA3 and 1 case show only TTF1 expression. CT10 was positive in 12 out of 13 cases, apical or luminal pattern. Carretinol was positive in 12 out of 14 cases. Regarding hormone receptor expression, ER was positive in 12 out of 13 cases. The range of positivity from less than 5 to 60%. PR was positive in 10 out of 13 cases, so the range of positivity less than 5 to 30%. 4 cases only positive for ER and 1 case only for PR, and 9 cases show both expression of ER and PR. Other markers, WT1 was negative in 26 cases, PAX8 was positive in 22 out of 23 cases, P53 expression show wild type pattern in 23 cases suspected for high-grade serous carcinoma, And markers of clear cell carcinoma, napsin A was positive in 2 out of 5 cases. HNF1 beta was negative in 2 cases. Here is an example of Mesonephric-like carcinoma associated with endometriosis. The Mesonephric-like carcinoma on the left side and the endometriosis on the right side. The Mesonephric-like carcinoma was positive for TTF1 in this image and the GATA3 that are negative in the area of endometriosis. CD10 show luminal expression in Mesonephric-like carcinoma and highlight the endometrial stroma of endometriosis. PR and ER was negative, completely negative in Mesonephric-like carcinoma and show some expression in the endometriosis. This case of mixed endometrioid carcinoma and Mesonephric-like carcinoma, the endometrioid carcinoma component show moderate to strong positivity for ER and was negative for ER was negative in Mesonephric-like carcinoma component. Regarding mutational analysis, was done in 20 cases, 15 cases, about 75% show KRAS mutation. Additional mutation was present and heterogeneous, like ARID1A, PTEN, TP53, BEX3CA, CTNNP1. 5 cases lacked KRAS mutation. One of these cases shows single gene mutation in TP53, and this case shows apparent P53 IHC, null phenotype. This patient presented with a FIGO stage 4 disease and recurred in 24 months in the lung. So this might suggest that TP53 mutation may be associated with aggressive disease. Regarding the clinical features, the age was ranged from 37 to 74 years. 19 cases presented at early stage and 13 cases at advanced stage. The medicine advanced stage cases were 6 cases to the abdominal peritoneum and omentum, 3 cases to the regional lymph node, and 2 cases to the lung and the pleura. 6 patients had a personal history of prior malignancy, breast, low-grade serous carcinoma, thyroid, and skin cancer. 18 patients had microsatellite stable tumors. All patients lacked the mutation in BRCA1 or 2. 2 patients show pathogenic germline mutation, MUTYH and ATM. 20 cases has family history of malignancy in the 1st or 2nd degree relative, predominantly breast followed by lung and colon cancer. Regarding recurrence, 26 patients had follow-up, 5 to 220 months. 17 patients either recurred in 15 patients or never achieved remission in 2 patients. The most common site for recurrence is the lung in 7 cases. 9 patients had no evidence of disease at the end of the follow-up. However, follow-up was limited with only 3 patients having a follow-up more than 1 year. Regarding survival, 13 patients were alive with disease at 18 to 220 months following diagnosis. 14 patients died of disease 6 to 45 months following diagnosis, and 7 patients lost the follow-up or had less than 2 months follow-up. The mean overall survival for extrauterine Mesonephric-like carcinoma was 166 months. However, the mean disease-free survival was 32.6 months. Regarding a comparison to the control group, high-grade serous carcinoma was most likely to be associated with presentation at advanced stage. Improved overall survival and disease-free survival was noted for patients with mets confined to the pelvis versus abdominal, peritoneal, or liver and lung mets. The extrauterine Mesonephric-like carcinoma, low-grade endometrioid, and the clear cell carcinoma were more likely to recur in the pelvis, abdominal peritoneum, and para-aortic lymph nodes than high-grade serous carcinoma that had propensity toward more distant recurrence. There was no significant difference between endometrial Mesonephric-like carcinoma and the extrauterine counterpart with respect to the presenting stage, the presence of recurrence, or recurrence site for overall survival or disease-free survival. Here is the Kaplan-Meier curves. The specific histotype didn't correlate with the overall survival. However, the high-grade, low-grade endometrioid carcinoma and the clear cell carcinoma associated with significantly longer disease-free survival than high-grade serous carcinoma and extrauterine Mesonephric-like carcinoma. For multivariate analysis, for overall survival, age was the only significant predictor. However, for disease-free survival, only the advanced FIGO stage at presentation was significant. So discussion, the clinical features and the histological and IHC features of extrauterine Mesonephric-like carcinoma were largely similar to literature. Regarding IHC, both GATA3 and TTF1 are recommended. GATA3 appear to be the most sensitive marker. This study shows more frequent expression of hormone receptors, 37.5% compared to the previously reported cases, 6% of all reported cases. The presence of staining for ER in more than 50% of nuclei shouldn't absolutely exclude the diagnosis of Mesonephric-like carcinoma when morphologic and other supporting IHC features are present. However, robust expression of both ER and PR is unusual and would argue against the presence of Mesonephric-like carcinoma. A second malignant component was present in 42% of cases. The most frequently encountered type, endometrioid carcinoma low grade. About 15 cases, 75% had the KRAS mutation compared to 87% of molecularly interrogated tumors in literature that had KRAS mutation. With key morphologic and IHC features, KRAS is not required for diagnosis. However, given that a KRAS mutational subtype G12C has a targetable therapy, it would be ideal to sequence all tumors in which the diagnosis is suspected. Additional mutations, many found in endometrioid carcinoma, is present as reported in the literature. The extrauterine Mesonephric-like carcinoma has a behavioral trends that more closely follow high-grade serous carcinoma than low-grade endometrioid or clear cell carcinoma. This study confirmed that extrauterine Mesonephric-like carcinoma is more aggressive than low-grade endometrioid carcinoma, underscoring that the correct diagnosis is important to ensure proper therapy and follow-up. So they recommend maintaining a high index of suspicion and low threshold for utilization of the IHC. The strengths of this study. This is the largest single institutional series, show detailed assessment and description of the histologic, immunohistochemical, and molecular features of extrauterine Mesonephric-like carcinomas. The tumor behavior compared to the more commonly encountered ovarian carcinoma as well as the endometrial counterpart. Areas for improvement, of course, we need larger sample size and longer periods of follow-up for confirmation of these data. Thank you.
Great, excellent. So we do have a question you might like to answer. How do you differentiate the Mesonephric-like from clear cell carcinoma on morphology? You want to talk a little about that, and I can chime in if you want?
I think Mesonephric-like carcinoma will have more variety in the architectural pattern. Like the ductile glandular pattern, this is uncommon in clear cell carcinoma. So the variety of emerging architectural pattern would be a point toward the Mesonephric-like carcinoma. Second, the presence of dense intraluminal eosinophilic secretions may be also a point toward Mesonephric-like carcinoma. The nuclear features, the clear overlapped nuclei with nuclear groups, is not a feature of clear cell carcinoma. By the IHC, we can use the GATA3 and TTF1. Napsin A may be not very helpful, as some cases of Mesonephric-like carcinoma show some expression of Napsin A. But GATA3 and TTF1 may be helpful in these cases.
Yeah, I think from the low power, the Mesonephric-like often has, frankly, a bluer appearance. More basaloid appearance. So I wanted to ask a question. So there was this one case mentioned with the TP53 mutation only, right? And I wanted to know if you have any thoughts on that. I think that they didn't show an image of it. I wish that we'd be able to see it.
I think it's an interesting case. I wish they put pictures of this so can see it and compare it to serous carcinoma. Yeah. I think they favored the Mesonephric-like carcinoma in this case, although it showed focal areas of high-grade atypia. This case was one of the cases that had foci of high-grade atypia. But they favored these based on the complete negativity for WT1, ER, and PR. Usually serous carcinoma would show some degree of expression of ER, even focal. the complete negativity for WT1, ER, and VR, and the positivity for GATA3 with CD10 make them favor Mesonephric-like carcinoma more over high-grade serous carcinoma. But sure, this is interesting. And I think all cases of Mesonephric-like carcinomas in the future should be studied for the presence of TP53 mutation. It is a feature that can occur and associated with more aggressive disease.
Yeah, it'd be nice to know more about that one case. Thank you. Okay, in the interest of time, we're going to move on to our third presenter, Dr. Sallagonda, if you want to share your screen.
Hello, Dr. Wolsky. Are you able to see my screen?
Yes, absolutely.
Okay. Thank you everyone for joining. My name is Archana Sallagonda. I'm a third-year pathology trainee at UMass Chamblay State Medical Center, Massachusetts. So the title of the article today is PTEN Deficiency in Tubo-Ovarian High-Grade Serous Carcinoma is associated with poor progression-free survival and is mutually exclusive with CCNE1 Amplification. The article is authored by Dr. Zhang et al., and this was published in Modern Pathology Journal. So PTEN is a tumor suppressor gene, and it acts as a negative regulator of PI3K pathway and thus downstream cell growth, signal, and proliferation. So PTEN deficiency has been identified in many cancers. Largely, they're found in the endometrioid adenocarcinomas, like around 37 to 61%, and also in multiple other tumors as well. So why do we have to know about this PTEN? So PTEN has got prognostic and clinical implications in some cancers. For example, in breast cancers, the low levels of PTEN is associated with poor prognosis and with ER negativity and unresponsiveness to trastuzumab treatment. And evidence shows that PTEN loss in melanomas is associated with resistance to immune checkpoint inhibitors. On the other side, PTEN deficient prostate cancers, they are more sensitive to PARP inhibitors. Though we see PTEN deficiency more commonly in endometrioid adenocarcinomas, the prognostic significance is still inconclusive. So the main aim of this study is that the authors trying to evaluate the PTEN expression along with the tumor profile, treatment responses, and outcome in patients with this tubo-ovarian high-grade serous cancers treated at a single institution. So 76 cases of tubo-ovarian high-grade serous cancers were selected, and pertinent clinical data was obtained from EMR. At least 1 to 1.5 mm diameter core punches were done from the representative tumor areas on each case submitted for tissue microarray. And about 8 IHCs were done on TMA blocks, PTEN, ER, PR, AR, CD8 and FOXP3 for intratumoral lymphocytes, and then PD-L1 scoring. So ER, PR, AR, they were semi-quantitatively scored. Coming to PTEN IHC, so they were categorized as 3, lost, retained, and subclonal loss. Lost when less than 10% of the tumor cells show any kind of immunoreactivity. Retained when more than 80% of the tumor cells, they show any kind of immunoreactivity. And in between, like at least 10% discretely positive and at least 20% of negative tumor cells showing staining is considered as subclonal loss. And molecular profiling was done in 51 of 76 tumor samples. 53 of 76 had germline genetic testing results. And to validate the findings in this study, genomic data from 1702 samples from TCGA database were obtained. So this is a very comprehensive table comparing the various clinicopathological variables considered in this study. So looking at this, we have 4 divisions in this. Second one is the PTEN deficient, then the PTEN intact, and the clinical significance. So the mean age of diagnosis for all these patients is 62 years. As we see, most of them presented in their advanced stage. And chemotherapy, platinum-based chemotherapy was a predominant chemotherapy regimen that was given. And the follow-up period was 42 months for all these patients, and approximately 22 patients were deceased at the last follow-up. I would like to discuss in the subsequent slides on patient response to chemotherapy and the institution of PARP inhibitors and the response to that treatment. So this figure shows the association between PTEN expression and the ER expression. So PTEN deficiency is associated with ER negativity or ER low expression. And this was the only finding that reached the statistical significance, but it did not reach the statistical significance with other variables that were included in the IHC in this case. So this is one image provided in the article, one example each of PTEN intact case and a PTEN deficient case. So the PTEN intact case, you can see that it's the ER, PR, and AR. It looks like it's following just the same way as like PTEN expressing and then ER is expressing. And the PTEN deficient case, we see that ER, PR, AR, they are kind of downtrend or decreased response. But coming to the clinical or the statistical significance, it's only ER which shows the statistical significance, but PR and AR, they did not reach the statistical significance. And total of 13 cases were PTEN deficient, of which 5 showed complete loss and 8 showed subclonal loss. So this figure shows the Kaplan-Meier curves for survival, overall survival and the progression-free survival. And again, if you see the red highlighted box, the progression-free survival shows statistical significance. So the patients with PTEN deficiency shows progression, decreased progression-free survival, but those with intact PTEN, they have improved progression-free survival. And there was no statistical significance related to the overall survival. So PTEN deficiency and the treatment response. So the authors have noted that 2 of the 11 patients with PTEN deficiency showed primary resistance to this platinum-based chemotherapy in comparison to 7% of PTEN intact patients. But of course, this did not reach a statistical significance, possibly because of the small sample size. And also, if you see 6 out of 6 PTEN deficient cases, they showed progression of the disease within 1 year of PARP inhibitor therapy. So the PARP inhibitors were used either as a maintenance therapy or as a treatment in those with recurrence. But again, this one did not reach the statistical significance. It was close to, but did not reach the statistical significance. So this picture shows the molecular profiling of the whole cases that we had. So overall, 46 cases had the molecular profile. And this one, the one in the yellow is the PTEN intact cases by IHC. And the one in the blue are the PTEN loss or the subclonal loss by IHC. And the second one is the PTEN by molecular testing, and we have only 2 patients with PTEN alterations. And as we all know, P53 is the most common mutation in high-grade serous cancers of the ovary. And in this study, approximately 98% of the patients had this TP53 mutation. And there were some germline testing done, and some of the patients had BRCA1-2 mutations in them. And there were several other gene alterations being identified. So interestingly, the authors identified that there were cyclin-E1 amplification is seen in patients with the PTEN intact cases, but not so in PTEN loss. So this was an interesting observation and the conclusion by the authors. And there were many other gene alterations being identified. So to confirm this association between the PTEN and cyclin-E1 amplification, the genomic data from 1702 ovarian high-grade serous cancers from the database were analyzed. And of these cases, approximately 21% of them showed the cyclin-E1 amplification, and only 7 of them simultaneously had the PTEN loss of function alteration. So this supports that both of them are mutually exclusive at the DNA level. So why is there a discrepancy in PTEN IHC and molecular alteration? As we see, like 46 of the 46 cases, like 36 had PTEN intact, PTEN is intact, and 10 cases had a complete loss. But if we look into the molecular profile, just only 2 cases, like which contributes to 4% of the cases, only showed the molecular alterations. And at the same time, the data analysis from the TCGA database also showed PTEN loss of function alterations in only 5.6% of the high-grade serous cancers. So discrepancy in this low rate of detection could be attributed to epigenetic silencing. It may not just be attributed to intragenic mutations or deletions, but there are some other additional contributions which is causing the low rate of detection by molecular testing. So in this study, the authors have demonstrated that the PTEN deficiency is not an uncommon occurrence, and it may have prognostic and therapeutic implications. And there is a statistical significant correlation or association between PTEN and ER expression, similar to other studies. And PTEN loss is a poor prognostic indicator as per many studies, but PTEN deficiency was an independent predictor for worse progression-free survival in this study. So there is a conflicting data on the prognostic value, like some tumors with PTEN deficiency, they have poor prognosis, and some tumors, it has got a good prognosis. So why is there a conflicting data on the prognostic value in different tumor types? Probably it could be because of the lack of standardized methods for PTEN status evaluation. So the authors emphasize that the need for larger nationwide studies and methodology may help us solve this issue. So the authors conclude that these findings indicate that the PTEN loss defines a distinct clinically significant subgroup of high-grade serous cancers like ER negativity, a wild-type cyclin E1, inferior clinical outcomes, and potential drug resistance, and that these group of patients may benefit from the combination of PI3 pathway inhibitors and platinum-based chemotherapy along with the PARP inhibitors. So standardized IHC techniques and scoring criteria for evaluating the PTEN status is warranted to confirm and explore the significance of this PTEN deficiency as a biomarker. So coming to the strengths, we have a very comprehensive table for comparison of the variables, and multiple clinical pathological variables were taken into consideration, like tumor stage, treatment response, survival rates, outcomes, and interesting observations were drawn regarding the hormone receptor expression and all this. But so the important conclusions were drawn, but most of them did not reach the statistical signification. But definitely the findings are hypothesis generating for future studies. So limitations. So the authors emphasize that PTEN IHC should be standardized and wider should be applied in clinical practice, but they did not mention about the IHC staining patterns, if there was any heterogeneous staining, and if they had any issues with the staining patterns or any interpretation. And so if one wants to apply it in clinical practice, I wish there was some description about the staining patterns being described in the study. And the other one is authors do not comment on the statistical power of the study to draw their conclusions. And the last one, which I thought was about the mutually exclusive mutations. Like they did mention about the cyclin E1 amplification in the PTEN intact cases, but what about the other cases where, like for example, in RAD21, we see that RAD21 shows amplifications in PTEN deficient intact cases, but we do not see that one in PTEN deficient cases. And similarly, likewise with other alterations like TSC2, FGFR1 as well. So if I did not know if the authors had a chance to look at these alterations as well, and if so, what were their observations? So that's all from my side. I would be happy to take any questions if you have.
Fantastic, thank you. So we do have one question. Because of the IHC molecular discrepancy, presumably due to epigenetic silencing, were the authors able to conclude that IHC is more superior than molecular in supporting the diagnosing functional mutations in these tumors?
Yeah, sure.
You can go ahead.
They did not mention which one is superior over the other, but they did mention that IHC being cost effective, and if wider studies are done and based on the observations, probably considering IHC to be a better cost effective way, it might be a screening tool to see if the patient, it might be a screening tool to see if there is any underlying PTEN mutations or even the cyclin E1 amplification, because it looks like the tumors with the cyclin E1 amplification, they have a chemotherapy resistance. So if wider studies are done, probably it might be used as a screening tool to look for any cyclin. It can predict that the patient has a cyclin E1 amplification, or the patient might be having a PTEN mutations at the molecular level. But with this study, they did not really mention about like which one is superior over the other.
Yeah, I think to the question at hand, this was not an aim of this study specifically, and so they don't specifically answer that question in this article. Okay, great. Well, with that, we can conclude. Thank you so much to all three presenters. You're all excellent, and thank you for volunteering your time. Yeah. See everyone next time.
Thanks, everyone.
Bye.
Thank you.
And
Thank you.
please,
Thank you.
as the audience signs off, please do answer the survey. We do look at your responses each time.